Well, we lower his cholesterol now because he leans out. We increase his muscle mass, right? There's never been a greater time for muscle heads like us than now, because all of a sudden what we've known all along has come true. Muscle is the longevity organ. Well, yeah, that's not a shock, but trends happen. And the trend right now is that muscle is correlated with longevity. Well, that fits in very nicely for people like us, doesn't it?
Yeah.
Because we're
It's
all
very
about the muscle.
vindicating.
It's very vindicating, right? So we don't look like dumb meatheads anymore. We're like, oh, this guy might have there's something to that.
Now we're
Perhaps
smart
we take it.
meatheads. Welcome to Iron Summit, the podcast where we dive deep into the art and science of becoming your best self, blending expert insights on strength training, smart recovery, optimal nutrition, and mindset mastery to help you elevate your game. Iron Summit is brought to you by Bridge Athletic. Looking for a way to streamline your training programs and deliver exceptional results? Check out our friends at Bridge Athletic. Their platform is packed with over 300 templates and 1,500 instructional videos, courtesy of subject matter experts like Exos, FMS, and Hyperice, making program design both efficient and impactful. Our listeners can take advantage of an exclusive offer. For a limited time, get your first 30 days free and your next month at 50% off when you use code IRONSUMMIT, all caps. That's code IRONSUMMIT, no spaces, all caps, for 30 days free plus 50% off your second month at bridgeathletic.com. Check it out and start assigning custom programs directly to your athlete's mobile device. All right, we're live. Welcome to the show. We have an awesome guest today. It's Dr. David Karli. Dr. Karli is a pioneer in regenerative medicine. He is the founder of the Karli Center, which is down in Miami, Florida. Prior to that, was a 20-year partner at the prestigious Steadman Clinic in Vail, Colorado, which is where I've met Dr. Karli. And before that, had a pretty impressive educational background in medicine. You went to University of Maryland for undergrad medicine, and then Harvard Med School for your residency, and really just at the forefront of human performance, regenerative medicine, supplements, and most importantly, is a meathead like us. So how was that? Did I get the intro better than Ryan?
Thank you, Max. I'm tired just thinking about all that. Jeez. That happened over a very long period of time. But
yeah,
thank
I can
you guys
imagine
so much. Yeah, thanks for having me. I appreciate it. It's awesome to be here, but also to support Max, who I really respect and appreciate what you've done, Max, in Vail with Mountain Barbell, and I've been the beneficiary of that as well. So glad to be here, and hopefully I can entertain your audience and give them some good info.
Heck yeah, we're excited for this one. This is like the perfect blend of science, medicine, and meathead, which is, it's a rare blend, but it's one of the reasons I'm such a big fan of you.
Yeah, it's a great blend. So what made you start with medicine? Why'd you decide you wanted to go into medicine?
Yeah, it's a bit of a saga. I'll give you the short version. When I was in undergrad, I was a good student, but something just happened and clicked, and I just started, I guess I just mentally and intellectually matured and just started acing everything out of nowhere. And I had never really thought, I was the first doctor in the family, and when I was pulling the numbers, my advisor at the time said, "Hey, have you ever thought about medical school?" And the answer honestly was no. I'd never really considered it, but I was pulling the numbers. So I just kept going and started investigating. So it kind of found me. It was a bit of an evolution. I wasn't the type of person that wanted to be a doctor since I was 3. I really didn't know. I was in a liberal arts college like many of us, and just had the good fortune to do well and kind of intellectually kick into gear at the right time, and things worked out quite well. But it was kind of a bit of an evolution, I would say.
I wish I just started acing everything.
It's a good problem to have.
I assure you, it was a bit of a surprise. I was working hard, right? It was,
yeah, of course.
It wasn't easy, but yeah, I call it a late bloomer, or, whatever was the case, but things kicked in at the right time. And I was fortunate enough to be able to get in and get through. Medical school is a bear. It is tough. Just the sheer volume of information is intellectually, drinking through the garden hose. So it was something, obviously to be proud of, and that I'm appreciative for the opportunity. Right.
I've heard the
What
stat,
path
like,
did you? Oh, go ahead, Ryan.
sorry, Mac. One thing here, I've heard a stat that like 9 out of 10 people that go through med school wouldn't do it again. Would you do it again?
I would, but with an asterisk. It's a bear.
Yeah.
It's not, you know, for me, what drives me, everyone's a little bit different in terms of what drives them. It's, can I do it? Right. That's the sense of accomplishment, and seeing how far I can go is really a driver for me, whether it's, physically or intellectually, academically, whatever might be the case. So you get an opportunity like that, I think you take it and just see what you're made of. And, if it doesn't work out, it doesn't work out. But um, the bigger problem, I think, is you give up your 20s. You're buried in a book, you're buried on the wards. When your buddies are out doing the 20s thing, you're dialed in. So you actually socially regress a little bit, I would say, compared to your colleagues who are living life, because you literally have one thing, and that's all you can do and focus on. I shouldn't say that. You have two things. You have medical school, and one other thing, you get to choose what that is, whether it's partying or an instrument or a spouse or whatever. You get medical school and one thing only, and that's it for 4 to 6 years, whatever, depending on what kind of track you're on. So the biggest problem with medical school is the social regression that occurs. You skip 4 years of your life. There's no ability for relationships. There's no ability for good friendships that you can sustain through that period. It's that intense and that focused. And I suspect, other professional schools, where it's law school, PhD or whatever, are similar in that capacity. But that is the asterisk, right? That's the thing. That's the sacrifice that you got to make. When some people are going to Europe to find themselves, you're buried in a book for
You're going to a
14 hours
library
a
to
day.
find yourself.
Exactly. Yeah. Exactly. That was the hardest part, I think. That was and you got to catch up then afterwards, right? So you get out, then you go to residency, and it's another 4 years of complete, immersion, and the social, the social casualty, that results from that. You got to play catch up thereafter, and emotionally, you're just not available to do much else socially that your 20-year-old friends are having a great time with.
What's funny is, and this is one of my favorite quotes, when I got to Lehigh for wrestling, my wrestling coach said to me, and you basically just said it. He said, Max, everyone wants to be good at 3 things in college. They want to be, or every athlete wants to be good at 3 things. They want to be good at their sport, they want to be good at school, and they want to be good at their social life. Pick 2. And guess which 2 I want you to pick. I was like, loud and clear. Oh, I did, because I have no social life anyway. So
yeah,
it was an easy
Max,
decision
I don't know
for
what
me.
your experience was, but high school sports was fun. College sports is work. It's a job.
Yeah.
Right. And
different.
if you're, on scholarship or whatever, it's fun too. But for me, I played basketball in college, and I had to pull the numbers to have a chance to get into medical school. And then I was battling injuries at the same time, and it was another bear. And but that's when you see what you're made of, right? And you see what kind of character you really have is under those types of conditions. When sacrifice is required, can you give it? Can you do it and sustain it? And some people can't. It's just too much.
I think too, like you're saying, it's a huge time commitment playing sports in college, but then at the same time, I feel like I always got my best grades in season, because it was like you didn't have time to mess around. You had to be so disciplined with your schoolwork. And it was like, you come home from practice, you better get it done, or like you're just not, you're going to fail that test. You're not going to get that homework assignment in.
Yeah, it's a great point, Ryan. The other thing that is beneficial is you're poor. You don't have money to do stuff. So there's nothing to do anyway, right? You don't have any money. So, and you're all in that situation. So you develop your little communities within the school environment or the team or whatever it might be. And that's your world. It's simple, right? You get out and you start living life, and the complexities start to happen, and it's hard to maintain focus. But when you're there, you have one thing to do, whether it's, get through academically or as a scholastic athlete or whatever might be the case. And it was just a simple time. And this, even medical school to some degree, was a simple time. You were able to just really dial in and focus, and you didn't have all these externalities, and the noise constantly barking at you that tends to occur when you get done all of that stuff and it's time to start a career, start making money, start a family, whatever might be the case. So there's a simplicity of it that was kind of nice looking back. Even though it was difficult, weren't the distractions, really. It was beautiful.
I agree with that. I think that's the reason. I'm sure I'd be interested to hear your take on doctors with this, but with student athletes, like a reason a lot of them struggle post competition, because that simplicity is gone. Like, you got to make decisions for yourself. When you're an athlete, you're told like where to be at what time from 7 a.m. until 7 p.m. And then you get done with that, and where do you go? Like, your decisions are all of a sudden yours.
Yeah, for sure. For sure. Well, I think that's part of why, you see some pro athletes struggle when, they get into all these resources and that noise, right? The fame and the money and the girls and, the whole thing. And they're just not accustomed to handle it. They haven't been there. And some of them really struggle with it. But I think they do a better job now than maybe in years past. Probably the best thing to do is get a good agent, right? Who's keeping wraps on you and not stealing money and so forth. But it's very, it's very true to life. In medical school, for example, you have a massive responsibility as a resident, for example. So you're a doctor, but you're not practicing on your own yet. You're in training, and the responsibility is still there. But then you get out, and all of a sudden, one day you're a resident, the next day you're done, and now you're a doctor. And it's a massive adjustment that first year. Right. So the burden of responsibility weighs down on a level that when you were a resident, you always had an attending doctor ahead of you that it fell back on him or her, right? Not on you as the final say. And then literally in a matter of 24 hours, it's like, okay, you're a doctor, go, you're on your own now. And looking back, it's a challenging time, but it's also when you're most vulnerable to, to screw something up is that inexperience of, you're transitioning, there's a lot to think about and do, and this responsibility, and now you got to manage your practice and people and, all these things. And it can be pretty humbling that first year out. So, it's kind of joke, if you're going to see somebody who just got out, make sure they got their head on straight, because that's when they're most vulnerable to screw something up.
Fair.
And while going through school, I know you mentioned you had like a basketball background. Where did you fit in the weightlifting, and obviously when did that passion kind of spark for you with kind of managing health and fitness and then also medical school at the same time?
Very late, well after all of that. I mean, I was very lean basketball player. I don't know, probably was 185, 187 pounds.
Hey, that's big.
And yeah, at 6'3", right? I was pretty skinny.
I'm just
right?
kidding.
We give Ryan a hard
crap
time because he's not 200 pounds yet. So
187, that's huge, right, guys?
Yeah. So coming out, I was always very athletic. So, but, in my 20s and even my 30s, I was pretty busy with, all this stuff going on. And that's a whole separate discussion. I think that would be fun is there's a cost to bodybuilding. Call it an energy cost, call it a time drain, call it whatever you want. There's a cost, and you have to do this, with the costs associated with bodybuilding or powerlifting or whatever it is your passion is, and your career and your family and all the other things. And you always have to be careful that, it's not tipping too far one way or the other. But to answer your question, Jonathan, I didn't really get serious about weight training until into my 40s. I worked out, but really to get serious about changing my body to look a certain way, very, very late in my 40s. Yeah.
Well, I want to come. Go ahead.
Yeah. And so you hear that when you start older, it's a lot harder to build muscle. What do you feel to say about that? Because my dad started when he was older too. He was like in his mid 30s, kind of late 40s, early 40s. And a lot of people say, oh, it's harder to start when you're older. So what do you say to that?
I think yes and no. Yes, from a practical perspective, especially if you're carrying orthopedic issues, which most former athletes are, because those are workarounds that you have to deal with and manage, whether it's a back or knee or hip or shoulder or pec tear. or whatever might be the case.
I think I have
that's
one
a
of each
sensitive
of what you
topic
just
here.
said.
So you have that to deal with. The body slows down in terms of response. But the key issue as you get into your 40s and beyond is hormonal, is the hormonal axis. And I went through that process too of your testosterone starts to decline in your late 30s and it continues. Some guys are able to keep it up naturally. Some guys are not. Some guys just get to the point where it dips low enough, you start to get symptomatic. What happens? Belly starts to form, muscle mass starts to go down, but even more important, your body's not responding. Even if you're pushing hard, you're not getting that positive feedback. And what happens? You lose interest because you're going to the gym and killing yourself and you're not seeing any result. That's one of the triggers, if you're in tune with it, to say, hey, let's take a look at this guy's hormonal levels, whether it's thyroid or testosterone or IGF-1 or, whatever might be the case. And it's still controversial, shockingly, which is ridiculous, that we should be replacing testosterone in men in their 40s and beyond. What an absurd notion that they're on steroids. I always make the joke that is your grandma on estrogen? She's on steroids. Estrogen is a steroid, right? So you giving her shit about it? No, you're not. So a guy who's symptomatic and low with regards to a hormone level, symptoms and level, you don't just treat a level, you treat symptoms in conjunction with the level, should be fixed, in my opinion. The data is clear. The risks are not there if it's done correctly and done safely. And we're not talking about pro bodybuilder levels here. That's a separate issue, separate topic. But for most men, to answer the original question, their body stops responding. And if they stop responding and they lose interest, guess what we lose? Health. We lose health along the way. So intervening to get the subjective part back. I feel better. I have my energy. I have my focus, my concentration, my drive, my libido. And guess what? That translates into better work in the gym and the body starts to respond again. Now you got a guy who gets motivated again. Well, we lower his cholesterol now because he leans out. We increase his muscle mass, right? There's never been a greater time for muscle heads like us than now, because all of a sudden what we've known all along has come true. Muscle is the longevity organ. Well, yeah, that's not a shock, but trends happen. And the trend right now is that muscle is correlated with longevity. Well, that fits in very nicely for people like us, doesn't it?
Yeah.
Because we're all
very
about
vindicating.
The muscle. It's very vindicating, right? So we don't look like dumb meatheads anymore. We're like, oh, this guy might have something to that.
Now we're smart meatheads.
Perhaps we take it to an extreme. I don't know. But then the question becomes, how much muscle is optimal?
That's a good question.
That's a good one.
Is it Max? Is it me? Jonathan? Is it you? We haven't
definitely
answered
not
that
Ryan.
question yet. Some people say, hey, the more the better, within reason. Other people say, oh, maybe the cost benefit ratio there starts to get skewed when you're training like a nut job, and the energy cost is high. So we don't have a perfect answer to that question, but unless you're really pushing advanced supplementation and you're just simply fixing something like testosterone, there's limits to what you can do, right? You can't get to a stage level with just a testosterone of 1,000, total.
I have a couple I want to get your opinion on this, follow-on questions to it. One, because you said a couple interesting things. One is symptomatic and low numbers, which I think is interesting for a couple of reasons. One is, and this will follow on to the second part of my question, like someone like myself, I do not have high testosterone. I have like 300 to 500. My best testosterone score ever was like 550. And my free test isn't like great either. That's like pretty low, like 10 to 15. But I don't have symptoms. Like I put on muscle mass well. I train hard.
He's horny.
Maybe I get hurt every once. So we didn't say that. But how does that happen? And then on the second one, like what is important in the numbers? Because I just saw a study that's saying like total test has actually very little to do with ability to add muscle tissue. It was more about androgen receptor density and free test.
Right.
So kind of like it's an equation, right?
Like the answer to your own question, Max. That's the answer to the question. most testosterone floating around your body is bound to protein. So another blood test that we'll do, SHBG, serum hormone binding globulin. You guys have probably heard about that, right? So it's kind of a rough measure of the protein that binds sex hormones in the bloodstream. So you could have a very high testosterone and a high SHBG, and you're free, you're bioavailable. So free and bioavailable is even another categorization now that's come to light. So the free testosterone of the total and free, which are the two that we usually measure, is the more important, but we should always be measuring SHBG. As an example, when I started testosterone, I think in my maybe 43, 44, somewhere around there, I had the same level as you, Max, but I was horribly symptomatic at the time. I mean, I was feeling awful. So it just goes to show you, to my point earlier, you don't treat a number. Someone may come in with a testosterone. If you're not symptomatic, in my opinion, you don't really need, to do anything at that point, but you can monitor because, you're young yet, but it will go down. Now, if you're rocking that number, you might be more sensitive to dips as you age. We'll see. But one of the explanations as to why you're not symptomatic with that number is your SHBG, or the bound testosterone in your body. The bioavailable testosterone is adequate to saturate your receptors, and you're feeling okay. And obviously, you're carrying a lot of muscle mass. So you walk into my office, I'm like, well, come on, could you really carry that kind of muscle with a symptomatic low testosterone? Highly, highly, highly unlikely. So there's a lot of factors that go into it, but you don't just treat a number is the most important answer to the question.
How long would you put somebody on? I mean, because I've never really messed around with testosterone levels, getting blood work and stuff. Probably should start getting, I don't know, trends of stuff like that. But I mean, it's super sensitive from everything I've read, and I don't know, we talk about it all the time. So how often how long would you try to reverse something naturally before being like, this person's a good candidate for something like that? If they can lower their stress levels, maybe they optimize their workouts a little bit better, they're sleeping better, maybe taking some kind of, I don't know, supplements or something, or
drink less alcohol.
Better. Yeah. Changing some lifestyle factors. How long do you give it before you're like, okay, this is more than just you kind of screwing up your life a little bit with some of these things?
Yeah, it's a great question, Ryan. Everyone is a little different. So you got to kind of read the person. How symptomatic are they? How much are they struggling? How's sex life at home? That can be a big variable, right? If that one goes south, the guy's not going to be too happy. So libido and so forth. So, if you look at oral supplements, tribulus and things of that nature, there's a very low, a couple percent, maybe 10, if you're lucky, if you really respond robustly to it. So that's one factor. Remember that testosterone supplementation comes in many forms. We can try to stimulate the body's own production of testosterone with things like beta HCG or oral medications that block estrogen and cause a secondary increase, but the testicle has to be able to make it, right? So what happens with testosterone decrease? Well, like an ovary in a woman stops making estrogen, the testicle stops or slowly stops making testosterone. So in someone who's kind of in the border range symptomatic, border range levels, we might try to still work with their body for a while to make their own, just with some stimulation of the signals that tell the testicle to make testosterone before we convert to an injectable type of testosterone supplementation. Now, why do that? Well, we want the body to make its own as long as we can. That's good. But also a guy who's on the younger end who may not be done having kids, if we go to a true testosterone supplementation, we shut down the testicle. It no longer has to make it. So what happens? You get testicular atrophy and fertility can go down. So in someone who's, late 40s, who has a young wife, for example, and she wants to have a baby, that's a factor that we have to consider, because once you go to a, testosterone cypionate or some type of injectable or pelleted testosterone, you're going to shut the testicular axis down and fertility may come down and you may interrupt their ability to have a kid. So those are all examples of things and factors that we consider when we look at the decision. But if there's a chance that the testicle might still respond to stimulation, let's give that a try and see what happens. So the three levels are exercise, weight loss, stress reduction, maybe an oral supplementation over the counter level is kind of phase one. Phase two is if that doesn't get us where we need to go, maybe try to stimulate the testicle to make more of its own. And if it still doesn't work, then, you're now into kind of the point of no return in that you're going to shut down the testicle from that point forward. Now, the question I get a lot is, well, what happens if I want to stop? So a guy who's on testosterone and decides all of a sudden I want to have a baby, is it reversible? And the answer is maybe, especially if you're younger, and especially if it's earlier in the course of testosterone. If you've been on it for 10 years, the likelihood of reversing fertility is lower than if you've been on it for 8 months, for example. So the longer you're on it, the less likely it is to be able to reverse back into fertility, and also keep the guy from going crazy because you take his testosterone. Right. So, there's, doing it poorly is easy. And I think, everyone's bombarded with, hey, send your information and we'll mail you testosterone, right, in the mail. But to do it really well, there's a lot of medical elements to it. You have to look at lifestyle. You have to look at a lot of variables. And, the perspective is don't do it if you don't have to. Or if you can work with the body, let's try, or let's do so as long as we can. But at some point, the testicle is just not going to respond anymore. And then it's a decision from the guy's personal decision on whether they want to take the jump to do actual supplementation. And there's counseling that's involved because they have to know what the risks are. The biggest one is your balls are going to shrink. Right now, there's ways to combat that. You can do testosterone with beta HCG. So you can give testosterone and stimulate the testicle, and the testicular volume stays even though you're on test. But now you got 2 shots instead of 1, and it gets really expensive, and you got to refrigerate the beta HCG, and it's kind of a pain in the butt. So there are ways to prevent the testicular atrophy if that's important to you. But most guys, if they're done having kids, say, I don't care if my balls shrink, whatever, who cares? As long as the wife doesn't mind, I'm good.
Yeah, for sure.
So can we talk a little bit about like some stem cells and PRP too? Because you don't just do like hormone replacement therapy.
Yeah, sure. Yeah, no, the hormone part for me is I just get asked a lot by guys, hey, would you mind taking over my hormone stuff? And I don't mind. I don't do a lot with women. It's mostly men's health stuff. I have gotten certifications and so forth in hormone, but my background really is in orthopedics and sports medicine and cell therapies, which is, where I've spent the better part of 20 years researching and developing that stuff. It's a fascinating topic. There's a lot of good, bad, and ugly to it. It's a little bit of the wild, wild west nationally, and then internationally even more so. But there's some. We try to create some logic and sanity and scientific legitimacy in terms of our approach to it, because you can get carried away with the hype and hope and bullshit, because sometimes we make stuff up, right, to appease consumer demand. People want these solutions. My knee hurts, my back hurts, I have Parkinson's, I have spinal cord injury. Obviously, we focus on the orthopedic part, but there's a lot of applications, as you can imagine, with cell therapies. And here's the nuts and bolts of what you need to know in the United States. Okay? And let's talk about the cells, and we can come back to PRP. Anything that is a live cell, a living cell, that did not come from you is illegal in the United States. Can't be used. So a placental cell, umbilical cord, Wharton's jelly, amniotic fluid-derived cell, culture expanded cell, a cell from another adult. There's not a single licensed product in the United States for routine clinical use that involves a live cell that's not your own, even though it's happening every single day in every single state. That is the FDA's position. Okay. Now, why is it happening? If that's the FDA position, you see the ads every day. You guys probably see, come in and get your baby cells. The answer is, overall, people aren't dying from it. So the FDA trigger isn't, getting activated unless there's a case where in a clinical trial, some people got blinded for macular degeneration. Well, that one's going to get shut down. Okay. There was a terrible outcome. So they put it in your knee. The likelihood that you're going to die is pretty low. You waste a lot of money. So the reason there's not a lot of enforcement is it's overall pretty low risk stuff that they're applying it to. Now, if they're putting it in eyeballs and spinal cords and brains, that's going to go south. And we're seeing some of the offshore stuff is now coming back, and they're not making this common knowledge, but you hear through the grapevine that some bad outcomes are occurring. So that's number one. What we're allowed to do in the United States is to harvest your cells, and that typically comes from bone marrow or fat, adipose tissue. Those are the two depots for stem cells in your body. We can concentrate them and immediately put them back into you. That's called autologous. That's an autologous cell. Autologous means from the cell. So I take yours, concentrate them, put them back in. I can't grow more. I can't genetically manipulate them or engineer them. I can't do anything to them that's going to alter them in any way. I can just take them out, concentrate them, and put them back in. Now, why does that work? The tissues that we focus on with cell therapies in orthopedics are all what we call avascular tissues: cartilage, meniscus, tendon, discs in your spine. Avascular means there's no direct blood supply. If there's no direct blood supply, stem cells can't get there. Blood and healing growth factors, biologically active proteins, can't get there. So those tissues that have a lousy blood supply can't fix themselves when they get damaged. That's why we all get back problems. That's why we all have issues with tendonitis and chronic tendinopathy. That's why pec tears take a while to heal, depending on where in the course of the tear it occurs. If it's in the avascular part of the tendon near the bony insertion, it's going to take longer than if it's at the myotendinous junction, the junction between the muscle and tendon. That's going to heal fast. So
that's why I tore mine there.
If the tissues have a crappy blood supply, there's an opportunity for us to do what? Give it a temporary capacity to heal. It can't get there any other way, so let's go get them from an area of high concentration, and let's park them under guidance, X-ray or ultrasound guidance, into the pathology, and let them do what they're naturally designed to do. So using your body's own cells, as you can imagine, is very low risk. You can't reject your own cells. You can't really have a terrible reaction outside of the potential for infection with any injection, but it's an extremely low risk thing to do. If it's someone else's cells, it's foreign DNA. And for a long time, it was felt, oh, these cells are invisible to the immune system. Well, it turns out more and more research is coming out that they're not invisible to the immune system. There was a recent study in mice where they injected, I believe it was umbilical cord, now I can't remember, but birthing tissue cell into IV into mice that were immunocompromised. So they lowered their ability to respond to their immune response. So they genetically engineered the mice to not have a strong immune response, put the stem cells in, and they tracked them. They labeled them so they could follow where the stem cells went inside the mouse's body. And even in the immunocompromised mice, they were gone in a matter of hours, no longer detectable. So if the immune system didn't recognize them, there's no way that would be possible. So this whole notion that younger cells are better than your own, in my opinion, as long as you're in reasonably good health, there's no scientific evidence to support that.
Is the adipose tissue versus bone marrow a better type of stem cell? Like, which one would be better and why?
Depends who you ask. In my opinion, bone marrow is better. We have a bit more data on bone marrow than we do adipose. We're doing some very interesting research on that very thing. So the PhDs that work for our biotech company, they identified subcategories of stem cell in adipose tissue there in Europe and published that information. We just did a pilot and we're in the process of applying for an NIH grant to actually do that same subpopulation analysis, i.e. there are different types of stem cells or what we call progenitor cells, similar concept. And as we continue to evolve, it's we used to think stem cells, we'll just put them in there and let the magic happen. We have to understand the scientific mechanism in terms of how they work in order to optimize them or improve them over time. We have to get away from the magic and how do we use these things or optimize things to drive more predictable and consistent responses. And that's a lot of the research work that my company does. So there are some of these subpopulations that are a little higher in adipose and some that are a little higher in bone. So they are a bit different. The only way to answer the question truly is to understand the cells, but match patient cohorts, similar patient populations, give one fat, give one bone marrow in the similar application to see which one is better in large numbers. So the second thing our biotech company does is we study cellular dose, the number of cells, and we match that to patient-reported outcome over and over and over and over and over again, thousands of patients. And then we look to see who did best with what type of cellular dose and then what type of stem cell. Does that make sense?
Yeah, absolutely. I'd imagine it's a little bit easier to get adipose tissue than bone marrow. Like it's probably less invasive to do something like that, or is that not the case?
99% of the people believe that to be true unless you do bone marrow really, really well, and then it's a breeze. It literally is a piece of cake. There's a lot of, we hear about bone marrow transplants and things like that. There's a lot of fear around the bone marrow procedure. It takes me about 10 to 12 minutes to do it. And I do it all the time under local or a little light, sedation. And people are like, oh my God, that's so easy. I don't know what I was so worried about. So the answer, if it's done well, is it's a very, very minor and easy procedure. Often can be done under local anesthesia only in the right patient. And it's a lot of myth around, it's so scary and so painful. I would argue, and my fat colleagues, my adipose colleagues would differ with me, that the adipose harvest is probably more uncomfortable than the bone marrow aspiration if you do it well. But both are performing similarly in the data that we do have in orthopedic applications. So one hasn't clearly shown superiority in terms of clinical outcomes yet than the other. My gut tells me that bone marrow will probably win out in the end, but I could be wrong. We'll see.
So once you would extract adipose or the bone marrow, how do you then harvest the stem cells?
Yep. So we're unique in that respect. We have a laboratory that is devoted specifically to that very thing. So different cells have different molecular weights. I'm going to take you guys back to school
I love it
for a minute. Different cells have different molecular weights. They weigh different, right? Depending on the size and what's in the cell and what it does. If you expose those cells to what we call density gradient centrifugation or high G forces, based on their molecular weight, they're going to separate in layers, right? And we know which cells separate in which part of something we call the Buffy code or the fraction of platelets and white blood cells when you expose them to high G forces. So if you know where they are in the layering process, you can then selectively go in there and get the populations that you want within reason. There's still some limitations, and we're not perfect at that yet. But that's how we separate them. And then we obviously have to be sterile anytime we handle a processed tissue. So that's done in sterile conditions under something called a laminar flow hood or a biosafety cabinet. So you ever see one of those big things with a glass and they're working underneath it and pipetting and doing all that stuff in the lab? So behind that glass wall, basically it's a vacuum, and we're able to contain the particulate matter in there and keep it as sterile environment, even though the room itself isn't a clean room. We're able to process the cells, and our technicians are specially trained to go in there and harvest the cell populations that we're interested in, and then collect those into a concentrate that we're able to reimplant either surgically or by injection back into the target tissue. And that process takes about 30 minutes. It's very fast.
So it's quick, because that was my follow-on question to that is, what about the stem cell banking?
Yeah. So stem cell banking is interesting, whether it's as a part of labor and delivery, birthing tissue, placental cells, or
even your own adipose, right? Some people offer,
right, or that, right? So you can. So the argument there is harvest your stem cells while you're younger, so that when you get older, you have your young stem cells ready to go. The problem with those models is a regulatory problem. It's fairly, if you do it well and you have the right type of conditions and staff, it's fairly easy to put these things on ice and cryopreserve them. Taking them out of cryopreservation and reanimating them back to life, because when they're cryopreserved, they're temporarily suspended in minus 80, conditions or very, very, very cold conditions. So there's a protocol that you have to very carefully not kill them when you thaw them out. Okay. But the regulatory problem is, the FDA says, well, you can go cryopreserve them, but you can't take them out yet and use them legally outside of some very specific and unique conditions. So if you bank your cells today, legally, can't take them out and use them yet. That's the regulatory limitation. Now, there are some exemptions. There's called a compassionate use exemption. Let's say you save some of your cord blood and your kid has a terminal cancer. You're able to apply to a special committee that evaluates your case and determines if it's appropriate to pull those cells out of cryopreservation and use it for a unique circumstance like a terminal illness. or
So
something along those lines.
why would you bank them unless you're just hoping that in the future regulation changes? Like that's
That's the only
basically why you're
reason.
doing it. Okay.
That's the only reason. Yep. Get them while you're younger, right? And so it's a great question I get asked all the time. Well, I'm 65 or 70. Do I still have good stem cells? And the answer is absolutely. They do decline slowly with time, but we're able to overcome the natural decline in stem cells through concentration when we concentrate them in the lab. So we might want a little higher stem cell injection in someone who's a 75-year-old diabetic than in you, Ryan, right? Because we account for the aging cell and also the natural decline. So we'll push that dose a little higher to try to get a good effect. So these are the nuances that we're teasing out. What is an optimal dose for a knee arthritis in a 75-year-old smoker? And is that the same as a 34-year-old weekend warrior? Is an acute problem the same dose need as a chronic problem? Is a meniscus the same as Max's pec tear, right? A one-size-fits-all solution is how we've looked at these things over the past 20 years. Concentrate them as much as you can, throw them in and let them do the thing. We're trying to tease out, no, there's a dose and response relationship here that is very complicated. So it depends on you, the person. It depends on the conditions of your blood. It depends on the conditions of your hormones. And now the new part we're getting involved in that I'm very excited about is looking at your genome, looking at your genetics, your DNA, and determining how your DNA signature affects the therapeutic capacity of your stem cells. That's part of the NIH grant that we're looking at. And to my knowledge, no one ever has looked at that in a large subset of patients. So in the future, we envision a type of model where you would enter your age and body mass index and medications and past medical history and all your blood testing that we do and your genetics and push enter. And the program would tell us what is the optimal characteristics of the product that we have to make to give you the best chance for success, predictability.
That's really
Sweet.
cool.
That's
Yeah,
where
that's
we
awesome.
want to go. That's what we're marching towards, all using your own cells, not a culture
Something
expanded
else's.
cells. And the other thing that's really cool about it is healing doesn't involve one type of cell or stem cell, magical stem cell. Healing involves the coordination of many different types of cells in your blood, in your bone marrow, and the stem cells that are in the tissues, as well as those other depots. So something called monotherapy is, okay, let's just grow mesenchymal stem cells or placental mesenchymal stem cells, billions and billions and billions of them, and let's just put those in. That's one cell type. Is that better than going in there and getting populations of all of the cells that are involved in healing and putting them in together? I believe it's probably better to stick to nature, what happens in nature. And the further we deviate from nature, the more likely we are to get bit in the ass and get a bad outcome or not have as good of a response. But again, that's stuff we're working through. That's my gut, but we'll see what pans out over time. What I tell patients is, I know your cells won't hurt you. So if we're going to invest in this and there's a reasonable chance that your cells can work in this particular indication, it's probably a pretty good avenue to go to.
What
So go ahead, Max. Sorry.
so bro science me. What is how helpful are stem cells? You have an injury, the surgical options, you don't want to go down that route yet. Like, for the layman, how helpful would you say they are?
Yeah. Well, there's two clinical scenarios to consider. One is helping a more acute injury heal better and faster. Okay.
Right.
Like a healing augmentation type of thing. So putting stem cells into your recently repaired tendon, right? That's not something you've had for 20 years. That's a recent, fresh injury. They work great in that situation. It's healthy, fresh, recently injured tissue that's bleeding. There's all kinds of inflammation markers and healing is already occurring. We're just helping it along. So in those conditions, we speed the pace of healing and try to prevent the potential for a re-injury by finishing the healing process more completely. Okay, so that's healing augmentation. The other scenario is like my knee coming out of playing basketball in college. I had jumper's knee, which is just a miserable injury for a basketball player to get. So it's where your patellar tendon pulls away from your kneecap and scar tissue forms there. And every time you jump, it feels like someone stuck a knife in your kneecap, right? and I played through it and I kept going, and it was terrible. And then I had it as an adult. So I treated that problem probably 14 or 15 years after I had done it. And the acute injury now became a chronic scarred, chronically inflamed injury, much harder to get better because of the scar. Instead of healing, it's scarred, and the scar tissue replaced what would be the normal tissue. We had to work that problem much, much harder over a longer period of time to try to stabilize it and get it to behave. And we weren't able to reverse it back to normal, but we were able to control the symptoms. So I treated that problem probably 14 or 15 years ago, and it's still doing fine, even though it doesn't look perfect on an MRI. So it's kind of, if you have the opportunity to address an acute problem and help it along in a sports medicine type situation or an acute injury, great. We probably don't do that enough. And one of the reasons I was able to develop a biotech company is the environment in Vail, which was, a destination market for kind of cutting edge, innovative orthopedic medicine, where that was important to people, right? They wanted the very best of the best of the best and were willing to pay for it. So we're able to develop and evolve this in a unique environment. And then just, over the years, it took on kind of a life of its own. When I started doing this stuff in the early days, it was snake oil. It literally was snake oil. But as someone who was traditionally trained to, inject steroids all day long, which don't have any contribution to healing. In fact, they probably slow and negate the healing process. I just felt there had to be a better way. And that's what led me into researching alternative pathways to stop the body from just feeling bad and help support the body to try to solve a problem instead of just put a Band-Aid.
Yeah, I want to, two things off of there. One, I want to touch on PRP because it's kind of like, it's a different mechanism, right? But similar idea to stem cells. It's augmenting and assisting the healing process.
Right.
And then two, I do want to dive a little more into what you just said about cortisone. So I know that's still kind of a controversial thing. I recently was just told to get cortisone injection in my back by a doctor for a bulging disc, which I didn't do. But I did talk to Dr. Karli about it. I want to touch on, let's start with PRP first, and then talk a little bit about cortisone.
So we talked about cell therapies, which are cells isolated from blood or fat and applied to an injury. PRP is where we concentrate the platelets from your blood, and in some cases, the white blood cells from your blood in addition. Okay, I will get into the weeds on the specifics of PRP. There are different types of PRPs, but basically it's a platelet concentrate. Platelets coordinate healing. Think of a cut on your skin, right? You cut your skin, it bleeds, and a scab forms. The scab contracts to bring the wound margins together and induces the healing process, and eventually the skin heals. Platelets coordinate that process. So they're coordinators of healing. Now you need cells and you need other things, to do that, but they're the signal. So we talk about tissue engineering triad: cells, signal, scaffold. You need all three to make new tissue. You need the signals to drive it. You need the cells, the building blocks or the bricks, and you need the scaffold, which is the frame. Okay. PRP represents the signals. So if you put PRP into an acute injury, there's still plenty of scaffold and there's still plenty of cells. They were just torn, and you're going to be able to heal that nicely. In a chronic degenerative disc, for example, we can't reverse that process back to normal. We can't regenerate it yet. We can make it feel better, but we can't regenerate it. So PRP is a very potent anti-inflammatory. It controls inflammation over time. And it appears we don't understand all of the mechanisms, very complex mechanisms physiologically that are involved in PRP, but it looks like it has what's called a neuromodulatory effect. That's what reduces pain. So inflammation control reduces pain. And then it appears to act on the nerve receptors to kind of deregulate them, turn the volume down on the nerve endings that are firing and giving you a chronic pain signal. So that's how we make things feel better with PRP. So again, acute situation, we're trying to stimulate healing. Chronic situation, we're trying to control symptoms, but we can't reverse that chronic situation back to normal yet. I hope in the future we'll be able to do so, but we're not quite there.
Would you ever put PRP and stem cells in together?
Fantastic question, Ryan. And that is exactly what we've been doing over the past year in studying to see if it's any better.
Okay, cool.
So bone marrow is a blood-based product. So when we make a bone marrow concentrate or a bone marrow stem cell procedure, there are platelets in there, but the platelet levels in bone marrow are lower than in peripheral venous blood. So what we've been doing is going and making PRP and making bone marrow concentrate and adding them together to increase the platelet count, which is naturally low. And so you get the benefits of PRP and the benefits of stem cells. Now you have in the regenerative engineering triad, you have cells and signal, right? So the only thing we're missing is the scaffold, and we rely on the native tissue to be the scaffold intrinsically. So fantastic question. We're looking at that. I think the answer is yes. Now, fat's interesting because fat isn't a blood-based product, so there are no platelets. So what a lot of guys do in a fat stem cell, or what we call micronized fat stem cell injection, they add PRP to it. Again, cells and signal. The more you stimulate the triad, regenerative engineering triad, the more potent anabolically this stuff is to try to get a tissue under control or hopefully heal.
And you were one of the first doctors while you were at Steadman Clinic to be really doing PRP.
Yeah.
Like in the country.
with the laissez-faire blessing of Dr. Steadman at the time, who was fantastic. Dr. Steadman was awesome. Rest in peace. So I was a young guy at the Steadman Clinic and was kind of just getting sick of throwing steroids into everybody, which I did really, really well, but didn't solve anything. It didn't solve any problems. It just made him feel better for a couple months. And back then we didn't realize just how, to get to your future point, Max, how bad they are for a tissue if they're done repeatedly. And that was the standard of care back then. Anyway, it led me to Europe through contacts of Dr. Steadman's to do some research over there. And eventually myself and a number of other colleagues way back in the early 2000s started looking at this. And I remember PRP is pretty simple. When we started early, there's a lot of pro athletes and stuff come through the halls of the Steadman Clinic. And I was in the Wall Street Journal and USA Today and for this innovative, incredible, thing we were doing, which was PRP basically back then. But it's interesting. What happens with most sexy medical technologies is you see this massive spike in interest and use, and then it kind of peaks out, and then it goes through the scientific rigors to see if it actually works, and then most of it dies. But what happened with things like PRP is it had that craziness, that initial bump in interest. It leveled off, but instead of dying, what it did is it leveled off, and then it started kind of more of a slow sustainability curve, indicating that there was something to it, something real scientifically, and was probably here to stay. And when I saw that leveling off and increase, that's when I knew there was something to this more than some elaborate placebo or, a bunch of BS snake oil that was going to run its course and just go away. So that's awesome. To answer your question, that's kind of what PRP is and how it evolved. PRP is good for basic orthopedic conditions, uritis, tendinitis, tendinopathy, or tennis elbow, for example, Achilles tendinopathy, those types of things, bursitis. It works quite well in those basic orthopedic applications. In my opinion, it doesn't work well in things like arthritis or a degenerative disc. And some of my colleagues would argue with me on that. But what we're seeing is it works, but it doesn't have a very long lifespan. You might get a year or something out of it, and then you got to repeat it. What we're seeing more with the cell therapy model is a similar response to PRP, but lasting much longer. I tell patients, if we're going to invest in cell therapy, I want years, plural, of control of the problem to make it a viable, and cost-effective treatment, because these things are expensive. With PRP, we just don't see that carry in the more advanced conditions. I've had PRP on my tennis elbow. I took it away. It never came back. So in those simple applications, it works great, especially if it's a high concentration PRP. And that's one of the reasons we got involved. We were spinning these things out in little medical devices like 99% of the people in the world. And something was coming out the other end that looked like blood that was called PRP, but I had no idea what dose of PRP was in there. And I just didn't feel like that was appropriate to charge people and not know the dose of the PRP I was giving them. That just seemed unethical to me. So we actually started from scratch a biotech company to first figure out how to measure the number of platelets in PRP, because no one had ever done it.
That's cool.
And then over time that evolved into stem cells and all the other things that we've done. We started that company in 2010. But we were, as a field, doing something that I felt was inappropriate, and that was giving a medication without knowing the dose. So if you have high blood pressure, it's like having 5 different blood pressure medication doses, and giving one of them, you don't know what it is, and you have to try to control that blood pressure. Doesn't make any sense, right? But no one actually took the time to figure out how to measure. So early on, that was very disruptive, and I was kind of Darth Vader early on in the field. But over time, little by little by little, they started to recognize, no, that is the right quality control measure that we should know. And now the research has clearly demonstrated that high dose PRP is a necessity. And if you're low dosing, you're likely to waste a lot of money for these people.
And so with PRP and stem cell and the healing processes, we know peptides are starting to become a lot more accessible. Have you guys looked into using something like a BPC, which has been used for like tendonitis or people who are dealing with localized injuries in your clinic, to try to use it as a kind of first wave of regenerative medicine?
Hey, you guys are excellent. I do podcasts all the time. I don't get these great questions. Tremendous work, gentlemen. You guys are on top of this. The answer is we're getting there. Peptides are a wacky space, and there was recent FDA activity on, going after them. Now it's a whole nother ballgame with the administration change coming. So we don't know what's going to happen with them. There's one study looking at injectable TB500, I believe. I think it was knee arthritis. It's a relatively weak study, but it was the first, and it showed some positive effect. Mechanistically, we still don't exactly know what some of these the peptides have evolved so quickly. It was the elephant in the room is they make lots of money, and so they kind of grew up a little too fast, in my opinion, without assuring safety and without understanding the why. Why did they work? Some things we know really well, like the old CJC and ipamorelin. Remember those days long ago? Yep. That seems like old news, but these things are evolving quickly for all kinds of applications, and there's great potential without question. But most of them are part of the signals to stimulate a secondary response in the body. Okay, whether it's stimulating growth hormone production from pituitary or some other mechanism, they're starting to become a bit more specific, like a peptide for diabetes or a peptide for blood pressure or a peptide for heart disease. So you're seeing that natural evolution, but the science is lagging behind a bit. So the long-winded answer to your question, Jonathan, is it's coming slowly. I think the better thing to study is probably just fixing the normal hormone axis of estrogen, progesterone in women or testosterone in men. And my theory, we're looking at this in our database, my theory is that if those things are deficient, you're probably going to see a blunted stem cell response therapeutically. So we probably should be correcting them.
Would that mean if you would have a higher likelihood of injury if you're deficient in your sex hormones?
We believe so. It's hard to prove that, Max, but I'll use one example that we know. Who gets Achilles tears? Who rips their Achilles? It's usually playing basketball or some kind of quoting sport. 40-year-old men, men in their 40s. Why would that correlate very closely to dropping testosterone, which happens in your 40s? Right? So, you'll see guys that rip an Achilles tendon, they go get it surgically repaired, and then 6 months later, they rip the other one. Right? So that's one clinical situation that's awful coincidental if you think about the age of men who rip their Achilles tendons with a declining testosterone level. So the answer is we believe so. We haven't definitively proven that, but it looks like there is an association. Yes, it does look like.
Obviously, this is a scale, but do we have studies on why, there's certain men that are 90 years old that have great testosterone, and then, some men drop off when they're younger? How do we, are we studying that stuff, or do you guys think about that and try to maybe mimic what somebody's body that naturally, I don't know, stays normal longer does?
Yeah. Another great question. We don't have a perfect answer, but I have to believe that goes to the genome, right? Just good genetics, right? You win the genetic lottery. what when I still lived in Colorado, my primary doctor was in his 60s, had a normal natural testosterone level of 800. Right. So I hate those guys. Right.
Never seen it. Yeah.
But hey, fantastic for them. That's wonderful. So I have to believe, Ryan, that it's just the genetic lottery in those situations. The other alternative explanation would be it has something to do with the specific cells in the testicle that make it, and they just have particularly robust cells that have a little longer longevity. But it looks like it's probably a genomic thing. It's an inheritable thing.
Well, as we're wrapping up here, want to get to the more meathead stuff. What's your current split looking like? What are your current goals? Yourself in the gym? Favorite just supplements, outside, not including protein because that's a food source, not really a supplement.
Yeah.
Let me hit the
ladder first. Let me hit the ladder first, and then
tell us about your supplements as well.
Yeah. So for years and years and years, I would get asked by patients, "Hey, what supplements should I be on? What are the best supplements? What brand? Where should I buy them? What's a fair price?" Literally, I got so sick of it. I got together with Zoe, my wife Zoe, and said, "I can't deal with this anymore. We're going to start our own line of supplements because I no longer answer these questions anymore. Because I don't know. There were so many brands, as you guys know, and so many products. There was no way for me to keep up to know if something was good, bad, or indifferent, other than the single condition that is it independent third-party tested, is what's on the label actually in the supplement, basic things of that nature. So we said, well, screw it. We're just going to go ahead and contract manufacture with, best and most reputable source that we can find. And we started, with the basics, your fish oils. And there are 5 universal supplements that I think most adult men, especially with orthopedic issues, can benefit from: fish oil, vitamin D and K, B complex methylated, multivitamin and probiotic. Those 5 basic foundational supplements can cover most men, and you got a pretty good foundation. Now you can go into the weeds and get as detailed as you want, but if you're just on those, that's a pretty good foundation. I don't believe we're at the point yet where we should base your supplements on genomics. We'll get there. But I see people saying, "Oh, I was told based on my genome that I should only take these 3 supplements." Well, what is a supplement? A supplement is something that supports your food, your nutrition, right? It's not just replacing a deficiency based on your genome. That would be treating malnutrition. It's supplementing what we know is a declining macronutrient level in our foods over, right? That's by definition what a supplement is. So I think it's really cool that people are recommending supplements based on your genome or epigenome. That's wonderful, but there's a greater opportunity to simply support who has perfect nutrition. No one. No one except maybe professional bodybuilders. No one. Do you have perfect nutrition, Max? You don't need supplements?
No. Okay. No, I take supplements.
Wait till you have the baby. Then your nutrition is going to go to shit, right? So,
yeah.
So there's an opportunity here to support nutrition, and we want people to eat good, and we want them to eat clean, and we want them to eat healthy. But the simple fact of the matter is the pace of life has become such that there is very little chance you're going to have perfect nutrition and get everything you need from your basic foods. It's just unreasonable. So enter the opportunity for good, high quality supplements that are controlled, high quality controls in terms of their manufacturing. What's in the label is actually in the product that can be tested, and bioavailability has been studied at least on some level to make sure you're actually absorbing the stuff, right? If you use B vitamins as an example, say, well, shoot, I take B vitamins and my pee is bright yellow, so it's not doing anything. Well, it has to go through your system to get to your kidney, and en route to your kidney, it actually performs its function. Okay, so those are the basic check marks that we use to kind of set up our foundational supplements. And then I happen to be colleagues with a guy named Anthony Almada. He's a nutritional biochemist out in Laguna, in California. Anthony was the guy who did the original research on creatine back in the 80s and 90s. He is kind of the father of creatine. And he started EAS. EAS was acquired and became this big company, ended up with Myoplex. You remember, I think you guys are old enough to remember some of those days. But Anthony was the guy that did that foundational research. So I went to Anthony and we wanted to do a super clean, new kind of innovative pre-workout. And we ended up creating this Z83 product, which is a really cool product. I don't know if you've been able to try it, Max. You should.
Yeah, it's good.
So it basically is a naturally sourced caffeine. There's three ingredients only: a naturally sourced, uber clean caffeine, um, a natural compound, plant-derived compound called Zembrin, which is a serotonin reuptake inhibitor. So it encourages serotonin levels in your brain, and then another neuromodulatory agent, ticrin. So the three things combined basically give you the benefits of caffeine without the downside of caffeine. What's the downside of caffeine? Jitteriness, anxiety, overstimulation, right? The bad part of too much. You're over caffeinated, right? So you get the positives of caffeine, and then the other ingredients offset the negatives of caffeine and give you calm and focus and concentration. So it's upside. That was the concept behind the product. So we put this together. Anthony put this together for us, and we tested it and beta tested it for quite some time, and the response was overwhelmingly quite positive. So we decided to go ahead and just take it to market, and it's still early in that process, but it is actually available, and so far so good. It's been very, very positively received, and I think there's a great market, right? Students, truck drivers, professionals, executives. I use it for gym applications. Now, we'll add some caffeine to it if I'm really trying to get after it, but it has definitely reduced my need for coffee. I don't really need coffee anymore.
Where can we find this?
So
if we
all of
want to
that
try
stuff all of that stuff is sourced through a company called Zeta Body, Z-E-T-A, Zeta Body, zetabody.com. And some of it's, like I said, some of it's white label contract manufacturer stuff, the basics. You can only make fish oil so many ways. You can't really innovate fish oil all that much. So some of it's just basic, high quality foundational stuff. We have the new Z83 product, and we have a couple products in the pipeline that Anthony's working on that are really interesting, including a creatine product that we're going to bring to market soon. The father of creatine should have a creatine product out there. So we went to him and said, hey, let's try to innovate something with creatine. So that's coming. So on the strength training side, I'm in your hands right now, Max. You put me on the Bridge program, and I've been following it, and it's been great. Actually, it was very timely. So I'm my own worst enemy when it comes to training, and I probably train way too heavy and way too much if left to my own devices, especially at 53. Mm-hmm. So Max said, hey, I want you to, I said, can I try the Bridge? And he was kind enough to let me try it, but it happened to be a volume training cycle. And I'm like, oh my God, that is way, way, way more stuff than I would normally do. So, but you know what? It was awesome for the joints. So thank you, Max, for that. They're incredibly taxing workouts, but to get through them, you have to bring your weights down or you can't get through the workout. So the volume was perfect, and my joints are feeling really good for the first time in a while because I was just training way too heavy.
That's the Iron Summit physique program. So delivered through Bridge, and that's awesome. When we were writing that program, we tried to have it so you could leave it in someone's hands at a gym without much coaching, and just the sheer volume made it so someone's not going to hurt themselves, but see results.
You get it.
I mean, it's the first leg day. I remember the leg workout is brutal.
That's great.
By the way, absolutely brutal.
Yeah.
And I was sore for a solid 5 days. And what was happening, when I was training too heavy is I was getting more joint soreness than muscle soreness, which is obviously what I wanted. And it was kind of a slippery slope where I just, let's go heavier, and it was just beating up the joints. So it was perfect and very impressive program that you guys put together. I look forward to continuing to work with.
Okay.
You have some, we have some big plans. This is, we just launched a community too. And so it'd be awesome to get you in there. We'll talk offline, see if we can do stuff like that. But this has been amazing. Thank you, Dr. Karli. This has been sweet.
I'd love to. Yeah. I think we're all best when we have a plan, when we have a strategy in the gym. So many of us, myself included, go through phases where you go to the gym and you train, and that's great, but you really don't have a plan. I'll end with this. I actually missed an important goal that I had set for myself that I still hope to hit one day, but it was in my 50s to hit 250 pounds sub 10%.
Okay.
Now that is not easy to do without advanced supplementation, right? But the caveats were an age management dose of testosterone on the high end, of age management, right on the high end of age management, and and maybe a little peptide or something to help support a little IGF-1 kick, and that was it. Those were the only two things supplement-wise I was allowed to do, and good nutrition and good training. So I got to 250, but I couldn't quite maintain 250 and get under 10%. I got to maybe 13 or 14. And this is, when I say percent, it's by DEXA, right? I don't
real
guess.
Body fat.
It's real, right? So a number of years ago, I was in an entrepreneur group, and I had to hit 5% body fat. It took me a long time, but I actually hit 5% body fat
On a DEXA.
But by DEXA, along the way, I lost 12 pounds of muscle to get there, right? So my body is one that the nutrition part is definitely the hardest for me of all the training elements. I can work as hard as I can probably push my body too hard. The nutrition part is the biggest, hardest part for me to get right. And I think a lot of people would probably agree. It's the hardest part to nail is the nutrition piece.
Absolutely.
Right? So I'm no different. Anyway, I wish you guys all the luck with Bridge and the new community. I look forward to seeing that. I know it's just launching, right?
Yep. We'll get you in there, and let's make it our personal goal to help you get to 250 sub 10.
It's going to be tough. It is going to be tough, but I said it on social media, so now I kind of feel like, well, I'm going to do it if I don't get
Let's
it. Right?
go. Yeah. I love it.
We talk about the energy drain, hitting that one. It takes a lot of energy, a lot of time. And I got to be able to focus, right? I'm doing these expensive, complicated procedures. So I got to be careful on the dieting, not to get into brain fog too deeply.
Well, I think
that's not very good.
I know the path, but I also don't know if Zoe, your wife's going to be that fond of it. We got to get you to like 280 with some fluff, and then bring you down to 250. That's the path.
I did the bulk, and I can do it. I just feel so heavy and terrible when when I go up there. I literally just feel awful and inflamed and just awful. So hopefully not, Max. Please no, not 280.
All right, 270.
I'm too old.
Awesome.
My heart will give way. Try to do that kind of stuff. So
thank you, Dr.
I appreciate
Karli.
the time, guys. Thank you so much for having me. It was a great discussion.
Thank you, Dr.
Thank you so
Karli.
much.
Yep.
You're
This
the
will
man.
be the
Thank you.
last time.
All right,
Thank you.
Max, I'll be out there next week. I'll see you in a few days.
See ya.
All right, bye.
At Iron Summit, we are about getting everything we can out of our workouts and everyday lives. If you aren't wearing a pair of barefoot or wide toe box trainers, you are leaving gains on the table. The Sashi Athletics Ronin Ichi Minimalist Trainer is a perfect barefoot shoe. Not only does it perform like other major brands on the market, it is actually good looking. Even my wife says so. Get a pair today for 10% off with the code IronSummit10. Link is in the bio.